right, thanks to everybody for joining us. I'm Matt Coleman from Rush. Really looking forward to our webinar tonight. I know people are going to be trickling in for the next couple minutes, but we're just going to get started in the interest of time and questions. We want this to be an interactive experience, so I want everybody to take a second before I start and kind of look at the controls. There's a Q&A button at the top. That's going to allow any of the participants to text questions in. We'll field those questions. We'll maybe call them out live in the webinar, or we'll potentially write back on the Q&A chat, but feel free to use that liberally. I'm really honored. We have 3 stellar fellows this year at Rush. Dr. Sullivan, Dr. Rush, and Dr. Shepard are here with us today to present some of the data. And I also have a special multidisciplinary guest, Gaurav Marwaha, from radiation oncology at Rush, is one of the people I lean on very heavily to help take proper care of spine tumors. And I think we work very well in a multidisciplinary way. And so he was nice enough to join us tonight. I'm not going to present overt presentation, but he's going to provide color and commentary and answer questions as we go. So Gaurav, thank you so much for joining us. And with that, we'll get started. So the topic is solitary or limited spinal metastases. How do you work them up, and what's the modern approach to limited metastatic disease? And I'm going to get to sort of why I think that topic specifically is interesting. But before we start, I want to basically have you understand that the workup, at the end of this webinar, I'd like you to be able to understand the workup, how to diagnose, and also potential pitfalls when you're dealing with solitary spinal metastases. I want you to understand the multidisciplinary approach and a histology-based approach on how to take care of these tumors. And also to really consider the spectrum of completely non-invasive, minimally invasive, or radical surgical treatments to optimize your patient's quality of life, local control, and survival. So no talk would be complete without a final exam before you start it. So I want everyone that's listening to the webinar to do these 3 questions for me. Don't agonize, just answer them quickly. So first one is, what are the following factors? Which of the following factors is a relative contraindication to standalone radiation? That means radiation without surgery for metastatic spinal tumors. Go ahead and vote. Click the radio button. There's just one answer. All right, cool. So we don't have to dwell on the answer here, but let's move on to the next one, please. So pretest 2, which histology has the best evidence in the literature to support wide margin spondylectomy, so en bloc surgery in oligometastatic spine disease? Okay, great. Okay, we had some answers, a little spread of answers. And then the last pretest question is, what is the essence of the definition of separation surgery? What best defines separation surgery? So number 1, circumferential cord decompression with SRS. Number 2, subtotal vertebral corpectomy followed by radiotherapy. Number 3, combination of minimally invasive spine surgery and proton therapy. Number 4, standalone stereotactic radiosurgery separating the radiosensitive tumor from the dura, or minimal conversation between the primary surgeon versus cyst during spine tumor cases. Sorry, it's a lame joke. Trying to bring some levity to this. Okay, great. All right, I'm going to move on. What this talk is not about is, there's a lot of interesting data, rhetoric, research, philosophy on how to deal with end-of-life issues in widely metastatic tumors. So how much to do for who, what's really the balance of quality of life and in the very few weeks or months that patients have left, how best to treat those patients. That's not what we're talking about tonight. We are talking about limited metastatic disease. So I'm presenting patients that have a single site or very few sites. They have excellent performance status. Their goal is for long-term cure or long-term local control if cure isn't possible. And we're going to still prioritize the relevant issues, which are quality of life, physical and neurological function, and mental function as well as local control and overall survival. So just a little bit of a different animal than I think has been very popular to talk about in the last 5 or 10 years in spine tumor surgery. Before I tell you why I think that's important, I'm going to present a case. So this is a patient my partner operated on for a clear cell chondrosarcoma in the proximal humerus. This was localized disease. He had a wide resection, and he did great for a year with this reverse prosthesis. You can see the glenosphere and the modular oncologic prosthesis. But he came in to my partner, who actually sent him to me, with new neck pain and some right C7 radiculopathy, subtle radiculopathy, no frank myelopathy, but really kind of hurting and all the red flag symptoms: night pain, constant pain not with activity. And so of course we obtained neck imaging. His x-rays look pretty good. Nothing major to see on the x-rays. But the CT scan, I'll just direct your attention over to the axial cut on the right. There's definitely a marrow and bone replacing process on that right vertebral body and right lateral process of C7. Okay, so we've got something going on. And I'm going to show you some MRIs. So there's a marrow replacing process in the C7 vertebral body. It really isn't involving supra or subadjacent vertebral bodies, but it does flare out into that lateral process of C7 and a little bit into the facet of C7. Fortunately, this patient has typical anatomy with the vertebral artery, so the vert is not in the transverse foramen at C7 typically, and it wasn't in this case. You can see the vert just anteriorly there on the right, free and just lateral to the longus coli. And this was needle biopsied from a posterior approach and consistent with clear cell chondrosarcoma. So same histology as his prior tumor. So I want to pull the audience a little bit here. I know I didn't give you a ton of time to look at that imaging, but he's 1 year out from his resection of clear cell chondrosarcoma. This is the same tumor back again in the neck in C7. He's not on a downward, very, a spiral course of neurologic issue. He's pretty stable, but we've got a problem here. And I'd like to know what the audience thinks. And by the way, I didn't tell you that this is still localized, so he has no other disease systemically. What does the audience think should be done? Should we do radiation and systemic therapy alone, so no surgery? Should we try to do a percutaneous ablation or cryoablation or a RFA? Should we try to do an anterior corpectomy, or should we try to do something crazy and take this out en bloc? So I'd like to hear what the audience had to say about that. Okay, let's see what the results are. All right, so about half of you said en bloc surgery, and the other half were split between intralesional treatment or no surgery and just radiation systemic therapy. Nobody said ablation. I'm not saying ablation would have been wrong or right, but hopefully after this talk, you'll have a little bit more of a thought process when it comes to ablation. All right, let's move on. So I'm just going to give a little background on this topic. The epidemiology of spinal metastases is interesting. It's a ubiquitous problem in patients with cancer. So if you have metastatic cancer, even if you never knew it, you probably had spinal metastatic disease. Up to 80 to 90% of patients on autopsy have involvement. The most common histologies that met to the spine are the usual renal, breast, prostate, lung, thyroid, and then of course myeloma and lymphoma. And up to 15 to 20% of all patients with metastatic cancer will have symptomatic spinal disease. But you should know that a majority, a preponderance, do not present with florid, widely metastatic disease. Actually, up to 60% to 70% of patients present with a single or one or two sites. So the most common clinical scenario that you're going to see is a patient who pops up with an incidentally found or symptomatic new single lesion. So I think it's important to talk about what the proper management is. And you should also know that while primary spinal tumors are rare, they're not as rare as people would make them out to seem. Primary spinal malignancy is actually just under 5% of all spinal malignancy. So most times it's not, but you have to be aware of the primary spinal tumors: chondrosarcoma, osteosarcoma, undifferentiated sarcoma, in adults being the most common ones. So how do these patients show up? Well, they're going to come into your office with no medical history, and they had back pain, or someone got a scan for some other reason, and now you have a new spinal site. I'm not going to go through the whole decision-making process of, is this bad or is it not? Because you can't work up every hemangioma that you see like it's a new tumor. But tumors that have soft tissue masses, tumors that expand outside the bone, tumors that are lytic, tumors that create a hole in the cortex, those are bad actors, and those are concerning and need further workup. So you will have patients that come in with just this solitary lesion and no other history. So obviously you're going to be, in that patient, you're going to be very careful to work this up carefully and obtain a diagnosis before you do anything. I think most people think that's pretty obvious. But what happens is these patients with a history of cancer, no active disease. So I had breast cancer 7 years ago. I was treated with lumpectomy. I had a little local radiation, no chemo. And now I have a new lesion in my spine. So it's probably most likely that patient has resurgence of breast cancer, but it's far from certain. These have to be handled with great care. Patients with cancer is a genetic problem, and patients with genetic problems, sometimes the genetic problem isn't necessarily sporadic, and there's some intrinsic defect. They can develop a wide variety of different types of tumors. This is another snake in the grass, sort of a pitfall. Patients that come in and they have known metastatic cancer, but it's kind of under good control. I've had an ALK positive mutation lung cancer for 5 years. My doctor says, yeah, I have some sites, but they're under excellent control. I'm on my chronic immunotherapy or targeted therapy regimen, and I'm doing great. But here I just developed this new back pain and I have a T6 lesion. What's the story? So this is a pitfall as well, because it would seem like if you have known metastatic disease, even if it's under control, that it's most likely to be that lung cancer again. And that's true. But you should know, for the last couple patients, the treatment for their prior cancer, like radiation, like chemotherapy, those can lead to secondary sarcomas and actually cause a completely different tumor in the region of interest. Not to mention, you can just have a completely de novo, a new primary tumor. And furthermore, the tumor it could be the same overall histology, but it could change receptor markers. So a breast cancer could be triple, or double positive, ER and PR positive, and then go to triple negative down the road with a metastatic site. So it's unusual, but it can happen. So you have to take great care to really understand what the actual diagnosis is when you see a new single spinal site. And then the last kind of general scenario, is that patients come in with very florid, active, widespread metastatic disease all around their viscera, and they come in with a new site. And that's the patient that it's actually quite hard to harm. I'm always sort of thinking about cancer as a chess game. Try to think a couple chess moves down the road. Understand, if I do X, what options do I take off the table? What options do I leave on the table? And fortunately, a patient with widespread disease in the viscera, even if you do intralesionally treat a chondrosarcoma in that patient, obviously their overall survival is limited because of their underlying disease anyway. So the first three scenarios are really ones that you need to be careful with and not make assumptions. I guess that's my long-winded way of saying don't make assumptions. So I'm not going to go in detail through the entire workup, but history is a massively important part of understanding what a patient's diagnosis is when you have an unknown lesion in the spine. what's their oncologic history. I check for physical exam findings and history for all the major common tumors. So smoking history, mammograms, goiters, blood in the stool or urine, all those kind of questions. I think, finding a spinal tumor in the lumbar spine mandates a full spinal axis MRI. I usually do a screening T2 sagittal. And you don't need to do a full diagnostic of the entire spine, but you should screen the entire spinal axis. And then a CT chest, abdomen, and pelvis, of course, looks for a primary tumor. That's not a staging study, that's a diagnostic study, to be clear. Labs, it's important to get panels on all the different possibilities. So SPEP for myeloma. If the patient has a lesion that looks blastic, like a prostate, then they can get a PSA. But really important to get a good BMP and CBC along with calcium and thyroid, parathyroid panels to make sure that you're covering all possible diagnoses. The vast majority of lesions can be diagnosed. Bruce Rugraf a long time ago wrote a paper and said that 80% of unknown lesions in an adult can be diagnosed with history, physical exam, and imaging. You shouldn't need a biopsy for most things. But in the spine, we often find that we're backed into that corner because there's just no other sites of disease, or there's the diagnosis just remains unclear because you can't find the primary. So the biopsy is really technically straightforward. I tend to heavily use IR for a posterior transpedicular biopsy. That should be done at the treating center. And it's invaluable to really talk directly with your biopsy colleagues, because you want to plan the biopsy in a resectable tract, and you want to make sure that they're targeting the correct part of the tumor that you're thinking about. Now, anterior cervical body, C2 body, those often need an open Smith-Robinson approach to get a proper clean biopsy. It's sometimes hard to needle those. And lymphoma is kind of a tough one because it's notoriously difficult to diagnose. You need a lot of sample. And if you give patients steroids, it's going to be hard to diagnose lymphoma because the steroids are very oncolytic. So there are some diagnostic difficulties, but this just underscores the multidisciplinary nature of what we do with trying to make diagnosis. It's important to talk to your colleagues to get this done properly. And staging, the staging is not well defined for how to stage these tumors. PET can be used, CT chest, abdomen, pelvis can be looked at retrospectively and considered a staging study. But the staging is usually disease specific. And I almost always get a bone scan to look throughout the skeleton. So in summary, the most common scenario with spine metastatic disease is actually limited disease. You have to take care with those lesions to make sure they're worked up and diagnosed properly and not make assumptions even if the patient has a cancer history, because you don't want to improperly treat a primary tumor. And if you make assumptions, you lose the opportunity to give targeted care to new kinds of metastatic carcinoma. So the remainder of our webinar is going to be all about what do we do when we find something and make a diagnosis? How should it be treated? Most of these patients aren't going to come in with a progressive sort of incomplete spinal cord injury with instability and obvious operative situation. A lot of them you're just going to find incidentally. So how should we treat that limited disease that isn't necessarily a disaster? That's the topic of the webinar. And I'm going to turn it over to the fellows to give we're going to do sort of a point counterpoint based on the case I showed you earlier, that chondrosarcoma to C7. We're going to argue what the best way to take care of that is, and we'll see who wins and who comes out on top in the end. I'm going to turn it over to, I believe, Dr. Rush to talk now.
Thanks, Dr. Coleman. So hey everyone, my name is AJ Rush. I'm one of the fellows, and I'll talk about intralesional treatments for spinal metastasis. I have no conflicts to disclose. A little bit of an outline. I'm going to give my own case example, or our own case example here from Rush, regarding intralesional treatment, talk about the evolution of intralesional treatment, separation surgery specifically, and hybrid surgery as they're more modern. Talk about the utilization of MIS techniques, and then I'll get back to why intralesional treatment would be the best option in treating the case that Dr. Coleman introduced. So briefly, just as an example of intralesional treatment, so 46-year-old female with a history of metastatic synovial sarcoma. She presented kind of the way Dr. Coleman described, back pain and an unremitting nature and radiating leg pain, and a CT chest abdomen pelvis did show a T9 pathologic fracture with a biopsy that confirmed synovial sarcoma. Otherwise, her exam was benign. Here it's kind of hard to make out, but she has a notable T9 compression fracture that I think is more easily identified here on the CT scan. You can see the lytic nature of this lesion. And then here's an MRI showing significant stenosis at that level. CSF effacement, no real cord signal changes or posterior involvement. I'm not really going to go into this. I think other talks previously have discussed this, but this is a patient with high-grade ESCC, definitely a high end of high end of indeterminate to sin score, but nonetheless, they have a radioresistant lesion, high-grade ESCC, so decompression and stabilization was elected. And in this case, we proceeded with a MIS type approach. We actually did T6 to T12 percutaneous instrumentation using Augmetics, augmented reality navigation. And then we were able to do a mini open T8 to T10 laminectomy and a T9 transpedicular corpectomy, really focusing on separation type procedure, removing as much tumor as we could, but really separating it from the neural elements and allowing for stereotactic radiation to follow. It's just a little bit of a complicated course due to rapidly expanding pancreatic mass, but nonetheless has done extremely well. 3 months post-op, has improvement in her pain, improvement in her mobility, and improvement in her quality of life. So a little bit of a historical perspective as far as the treatment, intralesional treatment goes. So prior to radiation therapy becoming kind of a mainstay in cancer treatment in general, laminectomy alone was the mainstay in treatment for symptomatic epidural spinal cord compression. But following the introduction of radiation therapy, laminectomy actually ended up kind of being abandoned due to multiple historical studies that showed no benefit of laminectomy and radiation as compared to radiation alone. And I think for the people on this talk, we can kind of all understand that not all compression would be able to be relieved from a laminectomy, especially when you're talking about a vertebral body type lesion. And so I think, as the basis of this talk, treatment and advancements in diagnosis and workup of metastatic lesions has gone on, and we're much further than where we were. And so now with vast advancements in surgical and radiation techniques, there's newer ways to treat these lesions as we're talking about. But I think the goals stay the same, right? As Dr. Coleman said, pain palliation, maintenance, or even recovery of neurologic function, spinal stability, and obviously improvement in quality of life in these patients. So what's intralesional treatment? By definition, intralesional treatment is removing the tumor in a piecemeal fashion to allow for debulking and decompression of the neural elements. This may improve the ability to then give adjuvant therapy. And of course, obviously a drawback from this is that by definition, you're not obtaining clear margins, and therefore you're not allowing for a curative process. And I think as you'll see in upcoming slides, the means by providing appropriate decompression have definitely changed since what I just said. It's not just a laminectomy, but specifically it's treating the area where the compression is occurring with intralesional treatment itself. And so this is kind of the Sentinel randomized control trial from Lancet in 2005, comparing radiation alone to direct intralesional decompression plus radiation for patients with symptomatic epidural spinal cord compression. So the primary outcome here was actually the ability to walk. And I think these are some busy graphs, but the numbers are pretty impressive. Post-treatment ambulatory rates, 84% in the surgical group versus 57% in radiation, retaining the ability to walk, median 122 days if you had surgery versus 13 with radiation alone. And then finally regaining the ability to walk if you had lost it, 62% with surgery versus 19% alone. And I think the secondary endpoints from this are worth noting. Maintenance of continence, 17 days with radiation versus a decompressive intralesional treatment, 156 days. You have vast maintenance of their Asia and Frankel scores. And I would say, a marginal but significant improvement in survival time. But I think this article clearly demonstrates the ability of direct intralesional decompression to vastly improve quality of life. And as such, it's been pivotal in changing kind of the standard of care for single level symptomatic epidural spinal cord compression. These weren't isolated studies. This is a 2009.
So AJ, just before you continue, I don't want to lose this point. You may mention it in a second, but what is different about, this is a landmark study. Everybody knows the Patchell study, but what's different about Patchell compared to modern times? Like what were they doing that we really don't any longer do in this trial? Did that come through to you?
No, actually,
I put you on the spot.
I mean, they were doing more complete removal of the tumor entirely, like a substantial debulking, not just separation type procedure.
It's true, but the radiation modality is totally different. So how was radiation different back then compared to now?
This is external beam radiation versus stereotactic radiation.
Right. So in this trial, it's inaccurate radiation. It's a shotgun approach, and because it's not shaped, collimated, accurate radiation, the dose cannot be very high, because if the dose is high, then you kill all the normal tissues around there. That's the orthopedic surgeon understanding of the physics. Gaurav, come correct me anytime you would like. But
yeah, that's absolutely correct. I mean, these were generally kind of much older school techniques, even for conventional external beam radiation. There was very little ability other than just putting a big block on the field. And typically we were treating in those days 1 or 2 levels above the issue and 1 or 2 levels below the issue, mostly because we couldn't account for the edge of the beam, or what we call the penumbra. So there were these big blocks that were the treatment fields. And so as we kind of moved through the early part of the 2000s, we got better at actually, creating some level of modulation so we could shape the beams a little bit more to the target. But again, this is even, before our ability to do SBRT, which is the most conformal techniques we have. So, study published in 2005, we were using techniques from the 90s in the study. So this is really, really old school stuff, 2 open fields basically. And we were causing, bowel issues sometimes with these treatments, depending on what level of the spine was involved, because we were treating high volumes of bowel to 30 gray. This could make people nauseous. There were some issues here, but nonetheless, I think it sort of set the standard for this combination approach. And fortunately, we've evolved quite a bit in our technical delivery of the treatment.
Awesome. Continue, AJ. Thank you.
I mean, like you guys said, so the idea of a intralesional decompression as compared to the time, at least conventional radiation therapy, it wasn't isolated. Obviously, it's been proven multiple times. This is a systematic review from 2009 showing quality of life measures are going to be improved with surgery, and even at the time, older modality radiation as compared to radiation alone. And I think what's really the most important takeaway from all this stuff is that the combination of surgery and radiation of any kind, intralesional decompression, is that we're getting histology or radio sensitivity independent results, so that people are having improvement regardless. But that's obviously been changing as radiation itself has been evolving along with our surgical techniques. And so, modern stereotactic radiosurgery can achieve excellent local control rates, 98% at 2 years. I'm sure Nick is going to touch on this probably in more depth than me. But like Dr. Coleman was saying, in the spine, previously, there's a limit to how much radiation you can shoot at someone before you're either going to damage something else in their body or damage their spinal cord. And so the idea behind separation surgery and hybrid therapy is really to allow for maximizing your radiation treatment dose while avoiding radiation-induced spinal cord injury and allowing for a safe distance between those. And so, this is a graphic from, I think, operative neurosurgery here, kind of showing the idea behind separation surgery. And so you're allowing circumferential excision of epidural tumor to really just reconstitute the fecal sac itself, kind of take out as much as you can from a posterior approach. And the goal really is just to provide 2 millimeters margin minimum for safe ablative radiation therapy.
And I'll just underscore there that that if you want to take care of spine tumors, you have to develop your circumferential decompression skills. So dorsal laminectomy is sort of the old way to do things, and it's been shown over and over again that that's just an ineffective, inadequate way to get tumor away from the cord and really to manage tumor in general. So you have to be comfortable, around cord level, going across the facet or doing a transpedicular or even doing a costo approach. In the lumbar spine, you have to be comfortable working in between the pedicles and in and out of the axilla of the nerve root to really make sure that you get that anterior tumor, because the whole technology, the whole approach relies on you clearing the tumor away from the neural elements so that radiation can do its job.
Exactly. Hybrid therapy, like Dr. Coleman says, really it's the idea of kind of rationale of utilizing both, right? We know that if you do circumferential decompression, you're going to have better neurologic and functional responses, and that you'll have good local tumor control if you use these newer radiation modalities that we have. And obviously a secondary benefit there that kind of goes into the next slide I have is that with the addition of stereotactic radiation and the separation surgery, you're now really focused more on a more minimally invasive approach to allow for these decompressions, because you're not trying to take out an entire component of the vertebrae, but really just debulk the tumor in a 360-degree manner, allowing for the ability for radiation to function. And so, this is a 2013 article, but basically just showing that this hybrid therapy is safe and effective at establishing durable local tumor control, regardless of your radiosensitivity.
I want to ask Gaurav Dr. Marwaha really quick. If Gaurav, as we fast forward 20, 30 years down the road and we have maybe microscopically accurate radiation therapy, do you think that surgery for these kind of tumors will go away? I mean, is there a way to get so resolved with the accuracy of the radiation that it's really all you need?
My short answer is probably not. I think especially for the high grade cord compressions, there's really no separation. And as good as we've gotten with radiation, we have to account for some area for the dose to fall off. So a lot of people ask, well, what, 2 millimeters, 3 millimeters, what is it you're really asking for and why in separation surgery? The 2 millimeters gives us just enough space for the high dose, the therapeutic dose, in 3 fractions, let's say it's 27 gray, 30 gray, to fall off to something tolerable to the cord, something on the order of 15 or 16 gray. That's the properties of radiation, and pretty much we've been able to get from a photon delivery platform, which is what most radiosurgery is done with. Now, there are some ongoing trials looking at proton radiation, and I just want to touch on it briefly because it's something that everyone talks about, but not that many people know that much about it. And even within radiation oncology, we have to accept there's actually a little bit of uncertainty with proton radiation. Even if you were to deliver it in a stereotactic method, you're looking at about a 2-3% range uncertainty. In other words, you don't know where that blast is going to turn up. And if you're a little bit off, that could be sitting right in the posterior aspect of your spinal cord, and you've got serious issues there. So just by the nature of the properties of radiation, I don't think there's going to be a way that we could get any more fine-tuned than that within a couple millimeters. I will say that there are now MRI guided delivery platforms that give us a real-time look at the radiation being delivered as we're delivering it. And so what that enables us to do potentially is to reduce our margins with which we treat. And it may help us shave another millimeter or so down, but it's not going to help a situation where we know that there's, the cord is being impinged upon, and we don't have at least some breathing room in between the tumor and the neural elements. So long story short is, despite all the advancements, there's always going to be some role to decompress, at least in my mind.
Thanks. AJ, I know we're slowing you down, but keep going. Thank you.
Oh, good. I won't spend too much time on this slide. I mean, it's, I think just beyond the expected oncologic benefits of hybrid therapy, this is an article that just demonstrates that also you have improvements in quality of life to accompany that. So just goes to kind of drive that home. And as far as MIS approaches, I think with increased evidence of the success of separation surgery, as we've discussed, more minimally invasive approaches to decompress can be utilized. If you have a posterior lateral epidural disease without instability, it could be reasonable to do a mini open or tubular type of decompression. Obviously, something that you might that already has instability or would necessitate a decompression that would cause iatrogenic instability. The construct like we did before that I showed, percutaneous screws followed by a mini open or tubular decompression, transpedicular, costovertebral is a reasonable option to again allow for again separating the tumor from the neural elements and allowing for radiation to get the durable treatment relief. And then Turo et al. 2017, very small study, 7 patients, but they were able to show using specifically MIS-based separation surgery. You can see relatively short lengths of stay, short operative times, low blood loss. I would say in patients that, I think normally we consider to be big surgery, high blood loss in sick patients. So it definitely a reasonable option with, again, good disease-free progression. So I guess back to Dr. Coleman's case, you have this metastatic 59-year-old with a C7 metastatic chondrosarcoma. They're having some bilateral hand numbness, radicular symptoms in the arm, CT with collapse. I won't go back through all the images. We just saw them, but obviously C7 body and lateral mass involved. It's not the most impressive amount of compression on MRI, but nonetheless, you have a radio-resistant tumor plus minus some early myelopathy, definitely C7 radiculopathy in a C7 body. And so hopefully I've driven home that this patient will be a candidate for intralesional treatment. You could do an anterior decompression, C6 to T1 anterior corpectomy, and then fusion, and follow that with stereotactic radiation. I think they'd have durable tumor control, again, regardless of the sensitivity. And then it's obviously a more minimally invasive approach. And I think it'd be effective at pain palliation, maintenance of their function, or even recovery of that arm pain and maybe the hand numbness, spinal stability, and obviously improvement in their quality of life.
It's incredible. We argued about this kind of approach. It's amazing to me how the radiation technology totally blurs the lines of what I used to understand as sensitive or not sensitive. Like, to talk about radiating chondrosarcoma is sort of sacrilegious, but the lines are being blurred as we've gotten more and more accurate because we can turn up the dose. Right. So yeah, in this patient without a ton of cord compression, it's very low-grade Bilski. It's got a pretty extensive tumor. We talked a lot about that kind of approach. So I kind of like, so far, AJ, of all the fellows, you've made the best argument so far. So I'm going to turn it over to Dr. Shepard, and he's going to talk about non-operative approaches for these kind of situations.
All right. Good evening, everyone. I'm Nick Shepard, another one of the fellows here at Rush. And then, so I'll be advocating for the use of non-operative therapies as a definitive treatment for spinal metastases, and obviously focusing specifically at this case. So I have no disclosures. I'll start with actually a second case, though. So this is a 66-year-old male. He had 2 months progressive mid-thoracic back pain, some systemic signs, otherwise no significant past medical history, normal neurologic exam, no evidence of hyperreflexia. This was his initial imaging on presentation. So he has this lytic lesion at T5. You can see there's a pretty extensive soft tissue component with significant cord compression at that level. His diagnosis and treatment underwent a biopsy, which was positive for multiple myeloma, which was oligometastatic, really kind of this isolated lesion at this point. So he initially got a dose of steroids. This was followed by conventional RT over 20 fractions, and then eventually he went on to get chemo and actually a bone marrow transplant. But following his initial treatment with the steroids, radiation therapy, and then chemo, this was his immediate post-treatment imaging. And you can see that there's been pretty significant resolution of that lesion across his thoracic spine. His cord compression has been largely resolved. And from a functional standpoint, his pain was significantly improved. So you can see that, for select cases in the right patient, isolated non-operative treatment modalities can be an effective means for treating these patients with metastases.
Nick, what other histologies can be appropriate for this kind of to watch the tumor completely just melt away with systemic and radiotherapy, aside from plasma cell tumors or myeloma?
So, there's a couple different types, I think that are traditionally thought of as being radiosensitive. Some of the different blood-borne malignancies that can metastasize to the spine usually respond well to radiation therapy. And
so like a lymphoma or a leukemia.
Exactly. I know you touched on it briefly in your question. I think there are certain types that are definitely considered as being traditionally radio resistant. One being renal cell, and then another being chondrosarc, which is the case being discussed. But as you mentioned, with improvements in a lot of the technologies and a lot of our non-operative treatment modalities, like you said, the lines are really being blurred into, what is actually radio resistant. And so that's one of the things that we'll kind of go over, is that with some of these expanding and improving technologies, cases that we thought were traditionally radio resistant, could be managed with, various forms of non-operative treatment.
Yeah, I would agree. And I would also as far as like obvious non-operative situations that without the whole issue of radiation technology, I think lymphoma, myeloma, and also germ cell tumors. So like a seminoma is another one that would be just exquisitely sensitive, and probably operation does not have much of a role unless you don't have the capability to radiate. So.
And with some of those ones that are particularly radiosensitive too, they can be managed with, conventional radiation therapy at lower doses, since they are particularly radiosensitive, versus some of these newer technologies, which may be, used more so for some of these traditionally radio-resistant tumors. And with non-operative options, I think it's important to think about them probably kind of in three different categories. One being medical therapy. We'll touch on corticosteroid use tonight. The other being percutaneous ablation techniques, and the third being radiation therapy, which really is one of the mainstays for non-operative treatment. And as we've kind of also mentioned, there are different forms of radiation therapy. I'll be talking about mostly accurate photon therapy tonight, but there are alternative forms, whether it's proton therapy, heavy metal and carbon ion therapy, that being a little bit more limited in its clinical availability. So, really at this point, I would say, largely accurate photon therapy is still the mainstay for radiation therapy. And when looking at patients and deciding, whether it would be, a case that would be amenable to isolated non-operative treatment, I think it is important to look at it from a couple different perspectives. I think the NOMS criteria or NOMS framework introduced from the group out at MSK, is a good way to interpret these patients. What you want to see is their cord compression and neurologic deficits. And again, some of these lines are being blurred with, improvements in our technology. But again, you want to be looking at the primary tumor histology to see, is it radiosensitive? Is it radioresistant? Is it something that can be treated with conventional radiotherapy, or is it something that may be amenable to SBRT? You want to be looking at spinal stability. Instability is a contraindication for isolated non-operative treatment. And then you want to be looking at, from a systemic standpoint, is it oligometastatic? Are there more or less than 3 vertebrae involved? What's the extent of the overall metastases? And general prognostic factors that, again, are important in really any decision-making tree for these metastatic patients. So starting with the medical therapy, corticosteroids, are still commonly used. This was one of the early studies by Sorensen from the 1990s. And it was just a single-blinded randomized trial comparing high-dose dexamethasone to no steroids in the cases of metastatic disease with cord compression. And what they found was that there was greater ambulation at 1 year, although there was no significant difference in median survival at about 6 months. So I think steroids are commonly used, and I would advocate for their use, but the current dosing regimens do vary pretty drastically between institutions. And this was a Cochrane review from 2015 that showed high-dose steroids really provided no significant benefit in a lot of the primary outcomes that we focus on, but were associated with an increased risk of adverse events. So a lot of the dosing regimens that we see commonly being used, are the either medium or low dose steroids, especially in cases of cord compression or neurologic deficit. And as Dr. Coleman mentioned earlier tonight, steroids can be oncolytic, especially in cases of lymphoma. So, just in terms of tumor treatment, it is important to have an established tissue diagnosis before initiating steroids, especially if there is a high suspicion for lymphoma. Moving on to percutaneous ablation techniques, these are pretty much used in isolation for, lesions that are typically away from the cord or away from any, important surrounding structure. So you typically kind of lesions contained within the body. So well-defined tumor masses without evidence of instability or neurologic compression. And then, as I mentioned, there usually is, at least some degree of separation between the tumor and the surrounding structure. So typically about, 5 millimeters or so. And two of the more commonly described techniques include RFA and then spine cryoablation, both of which involved introducing a probe, typically through a Jamshidi needle or some other introduction device, and then using either monopolar or bipolar probes in the case of RFA, or a freezing probe or a cryo probe in the case of cryoablation. And cryoablation is a little bit special in that it induces freeze and thaw cycles that you can actually monitor in real time during the freeze cycle. So it does have the added benefit that you can actually monitor real time freezing and thawing, which induces that tumor necrosis, which is the end goal.
That's kind of the chief difference between those two. The only problem with the cryo is that we have some evidence that the kill of tissues goes beyond the ice ball. So it's I think about the ice ball, the freeze thaw ice ball in cryotherapy as monitorable, but like a little bit harder to control than a radio frequency ablation. I trust it. I don't use it all that much. I don't ask for it very much because I don't trust the ability to control the margin. And that's where laser interstitial thermal therapy comes in, which you're about to talk about.
Exactly. So perfect segue. So, LITT is really the flip side of cryoablation. So instead of inducing a freeze thaw cycle, you're using thermal technology to induce tumor necrosis. And the added benefit, or the significant benefit of LITT, is that you can actually monitor in real time using a thermal MRI, where and the amount of tumor necrosis that you're inducing. So it allows for precise, accurate tumor essentially destruction. And essentially, it can be used almost in lieu of a surgery to induce some degree of separation. So one of the most commonly described applications is using LITT with SBRT as an alternative to separation surgery. And what some of these early studies have seen is that there is significant reduction in tumor volume, significant pain relief, and very good local control. So this is definitely one of the newer technologies that has a lot of promise. And moving on to radiotherapy, again, I'll be focusing mostly on accurate photon therapy for tonight, and in the sake of time. But this is the study I think AJ actually mentioned briefly. It's a study by Young that was a randomized trial looking at metastases that were managed either with laminectomy and radiotherapy or radiotherapy alone. And granted, a lot has evolved since this time. This study was in the 1980s, both in terms of surgical techniques, instrumentation, as well as non-operative radiation techniques. But what the authors noted here was that there's equivalent outcomes between surgery with RT and RT alone. So this helped kind of push the paradigm of the use of radiation therapy for the management of spinal metastases. And as especially during this time, and then over the course of the next 10 years or so, as we mentioned, the mainstay of radiation therapy was more of conventional external beam radiation therapy, which does have some limitations. And this was the other study that AJ mentioned, the Paschal study that was kind of a landmark study published out of the Lancet. And I know, in discussion, we kind of brought up, that this was, one of the studies that pushed us towards, more of a surgical approach. AJ went over the outcomes pretty well, that highlighted that surgery for this particular group and this particular study, did produce better outcomes. But as we discussed, the types of radiation that was being conducted in this study, was a little bit archaic relative to kind of our current day treatment options. So with this study, it's definitely something to take with a grain of salt. And the new treatment options, or one of the newer treatment options, and really the mainstay for accurate photon therapy for a lot of these treatments, is going to be that stereotactic body radiotherapy, or SBRT. And you can see in this kind of cartoon on the right, SBRT uses preoperative MRI, preoperative CT, CT myelograms, to really produce highly conformal high dose radiation. And so you're able to produce a high dose, high gradient, meaning there is a steep fall off between your targeted area of radiation and the surrounding tissue. And because of that high gradient, you're able to induce, higher doses, almost 3 times higher than conventional external beam radiation therapy. So with those higher doses of radiation, you're able to induce, better tumor control. And the dosing regimens for this still vary, pretty significantly. It can be given as a single dose, which is that stereotactic radiosurgery or SRS, or it can be given in multiple fractions. But in each of these cases, the individual dose per fraction is still significantly higher than what would be tolerated with conventional RT. And what's the data shown for this? So there's been numerous studies since the widespread use or widespread incorporation of SBRT as a treatment modality. And the take-home message is that it really produces durable local control that ranges anywhere from 70 to 100%. It's been used in a variety of cases, not only in instances of separation surgery, but as an isolated treatment modality, in addition to following conventional radiation therapy. So there is a lot of applicability for this treatment, and I would argue that it is a viable treatment in itself. And
so now you're telling me that I'm out again. No more surgery.
I think for the right patient, I think radiation therapy can save a lot of the the potential risks associated with even separation surgery and definitely an en bloc. So I think in carefully selected patients, radiation therapy is the way to go. And who those carefully selected patients are, I think that definition is definitely expanding. So we've talked tonight about cases of cases of metastatic spine disease with epidural compression. So this is kind of the Bilski classification, which attempts to grade that degree of compression. And traditionally, radiation therapy was confined to instances where there's no abutment of the cord. Again, because the conventional techniques offered a lot of kind of scatter with a lot of radiation that did spread to the cord. But with newer techniques, this has been expanded to include, not only grade 0, but grade 1 traditionally. And in some cases, in some rare cases, it's been expanded to grade 2, especially in cases of radiosensitive tumors.
Gaurav, are there groups around the country that are pushing the envelope when it comes to higher grade 2 and grade 3 Bilski cases for standalone radiation? Or is that still kind of faux pas?
Yeah, I mean, in general, we try to avoid it for the, definitely for the 3s and most of the 2s. I think what ends up happening with SBRT is you end up having to underdose at the cord, so you can basically treat to the cord tolerance. Why is that important? Well, you're probably giving some subtherapeutic dose to actual gross tumor, so you may control it for a short period of time. But ultimately, it's going to cause more issues if you don't get it under control the first time around. And secondly, the risk of myelopathy or kind of long-term damage to the cord is significant if you're actually treating spinal cord to therapeutic doses for SBRT to treat a tumor. So most groups, even the ones that have really been pushing the envelope in terms of dose escalation, have typically avoided the grade 2 and grade 3s. Grade 1s, I think, with some of the technology improvements, you're able to get a decently sharp fall off and be able to do it. But even for those, I would advocate for separation if you're considering SBRT. It's a different situation with conventional external beam because you're not using the high BED or the extremely high dose per fraction. So completely different conversation there. But for SBRT specifically, you do need some space to do it safely.
Thanks.
So that's kind of a nice segue into, non-operative therapy isn't without its faults. With radiation therapy, there is going to be, the risk of toxicity to surrounding structures, and especially in spinal metastases. That does include critical structures, obviously the spinal cord, the vertebral body, surrounding neurologic structures, and then obviously soft tissue. And one of the most commonly reported complications with this type of treatment is vertebral compression fractures, And that's particularly true with SBRT, again, because you are able to induce higher doses of radiation. But what we found is that limiting that radiation dose to less than 20 has been associated with a decreased risk of vertebral compression fracture. And as we just touched upon, the cord maximum dose tolerated, which is generally around 14 gray. If you're able to keep it below that dose directly adjacent to or on the cord, then the risk of myelopathy also drops. So two things to consider when trying to create your treatment regimen with RT. And this is a busy slide. The best things I think kind of want to try to highlight are, radiation therapy, again, is a viable, isolated treatment modality for spinal metastases in cases of patients with high function that have evidence of spine stability, mild, no to mild cord compression, but can be used in both cases of radioresistance and radiosensitive tumors, but are typically more helpful in oligometastatic disease, cases where the number of levels involved is typically less than 3. So finally, circling back to our case, this was a case looking at, from a NOMS perspective or NOMS framework, their primary complaints seemed to be neck pain. They did have some stable neurologic kind of radicular findings. They had mild, maybe Bilski 1 compression. They, was a chondrosarcoma, which is traditionally thought of radiation resistant, but no real obvious evidence of instability. And it was oligometastatic disease with really only one isolated body involved, without evidence of significant diffuse metastatic disease. So that's why I would argue in this case, doing a course of radiotherapy saves you from having to do, a big whack with an en-bloc resection, and even saves you the risk of having to do separation type surgery, especially in a patient without significant neurologic findings, and that really kind of has an isolated lesion that I think, from my perspective, could be addressed from radiation therapy alone.
Awesome. Good argument. So we're going to let Dr. Sullivan, I know we're getting late here. We'll try to finish by 1:15. But before we show you what we actually did, I want to give Dr. Sullivan the chance to present his argument for a more radical approach to this kind of a case.
Thanks for finally letting me get a word in here, guys. I appreciate it. Let me get this pulled up real quick. First of all, I want to thank my colleagues for presenting some compelling arguments tonight, but at the end of the day, I think most of us, at least here, are surgeons, and we're familiar with the adage that if you want something done right, you've got to do it yourself. At the end of the day, there's really no substitute for physically removing the entirety of the tumor. So here we go for a presentation on the arguments for en-bloc resection. So why do we shoot for this? When you look at data on en-bloc resection for metastases, there have been multiple studies showing that negative margins maximize local control, and they correlate with survival and extraspinal carcinomas. This has been something that's been hit particularly hard in regards to renal cell, at least on the orthopedics boards and the in-training exam. There's also some data that shows that with en-bloc resection, you get greater structural integrity when you reconstruct lytic lesions. That's for joints literature or megaprostheses, but it conceptually holds a role in spine disease as well. I think is an interesting point to consider. So here's a number of studies that have come out over the years, basically reiterating what I just said, that wide resection reduces recurrence, reduces revisions, improves survival, reduces recurrence in a number of different studies, as well as states that it improves implant survivorship, at least in the case of renal cell carcinoma. So what about in the spine? When you look at chordoma and chondrosarcoma, studies have shown that negative margins improve your local control and again reduce your incurrence. There's also an increase in survival and an improvement in prognosis as well. And it's interesting to know that en-bloc resection of the vertebra was actually initially described for chondrosarcoma. And again, when you look at solitary spinal metastases and oligometastases, negative margins, again, reduce recurrence and improve survival. So kind of a common theme here as I say that over and over again. Here's a number of studies, again, over the years, evidencing that sarcomas have reduced recurrence after spondylectomy, metastases have reduced recurrence, negative margins improve survival, positive margins increase your risk of recurrence. Over and over again, same story. So who's an ideal candidate for an en bloc resection?
Hey, Barrett, not to rain on your parade, but I just want to, I don't want this, you presented a lot of really good evidence and the evidence is out there. My major problem with all the wide en bloc series showing higher survival for what shouldn't be a curable tumor. I mean, it's a metastatic tumor. It's already accessed to systemic circulation. So how could that improve survival? The intrinsic bias that's really hard to get over is that the people that get wide margin surgery usually have more limited disease, better prognosis, better performance status, more easily resectable, smaller tumor. So there is a selection bias that's very, very hard to overlook. But I do think you presented the important papers, and I'm interested. But sorry, keep going. I wanted to say that before we moved on.
It's an excellent point, and I think that our case discussion is even a little bit biased to a certain degree when we're focusing on oligometastases, not widespread disease, and that's what all these all the papers I just presented were focused on. And again, as I go on in this slide, I'm about to say who's the best candidate who we're going to shoot for an en bloc resection. We're looking at someone who's already got a good chance at doing well, and we're trying to optimize that chance and give them the best chance that they have to have the best outcome for as long as possible, potentially even shooting for a cure. And those patients are people with solitary lesions, oligometastases, ideally with a long latency between when they were initially diagnosed and when the lesion shows up, people who have excellent performance status, and people who have a great survival prognosis. So like you just said, the person you're going to shoot for the moon on is the person who obviously already has the best chance at doing the best. So again, definitely a little bit of selection bias there. So before, I'm going to drop a case example here before circling back to our original case. In this case, we have a 75-year-old female. She was independent, highly functioning, presented to spine clinic with a year of insidiously worsening back pain. Had a pretty remarkable past medical history, having had a high-grade sarcoma of the left thigh, resected 4 years prior to her presentation, subsequently treated with radiotherapy and chemo. A year after that, she had a metastasis to the lung, which was treated with a partial lobectomy 3 years prior to presentation. So 3 years with clinical absence of disease. And she did have a history of DVT, a history of thyroid cancer, which was treated remotely with a thyroidectomy. Her exam was normal. These are her radiographs. A little tough to see here on the plain films, but there's a lytic lesion in the thoracic spine. MRI, stir and contrast images showing tumor enhancement and edema within the vertebral body. As we look at the axials, we see at least some particular involvement in the image on the right. And when we look at epidural spinal cord compression, we're talking about probably a grade 2 on the Bilski here with just a trace amount of CSF left. So in this case, as we talked about, radiotherapy, not really a great option. Separation surgery, definitely plausible option. This patient actually underwent a vertebrectomy, partial corpectomies of the adjacent vertebra above and below, placement of an interbody expandable cage, and posterior stabilization, in a total en bloc spondylectomy fashion with negative margins. You may say with her history and her age, this is aggressive, but it's worth noting this patient went home in a week. Her survival was out over 2 years. It's the longest outcome I could find in our data, or our chart data. And at every time point after that, she was improving her pain and her function. So she did well. So how do we predict who's going to do well? My colleagues have touched on a couple of these classification systems, but I'll present a few more. There's the Tomita classification. This one looks at what their primary tumor is, whether there are metastases, ultimately using that as a proxy for who has the best options, the best possibility for long-term control. And again, that's a patient who's going to do well, someone we're going to recommend an aggressive treatment for. There's also the Takahashi scoring system. Again, similar concept, looking at the type of tumor, the types of metastases, in this case, introducing a neurologic component and stratifying on the basis of score criteria. It's worth noting here that when you look at scores of 9 to 11, deciding between palliative or excisional, they do use the concept of a single lesion or an oligometastasis to push you more towards the concept of an excisional surgery rather than a palliative surgery. And then more recently, there was the SORG nomogram, which was released predicting survival. Again, using a nomogram approach and adding a couple more data points in here, including time of surgery laboratory values and performance scores as well, using that to predict 30, 90 and 1 year, 90-day and 1 year survival. So another important concept when we talk about en bloc resection, it's a different animal from the extremity where you can just remove a chunk of tissue. In the spine, things are complicated by the fact that you have the spinal cord running right through the middle of the tissue that you're planning to resect. And so it requires a careful surgical approach and surgical planning. Boreani presented this classification where basically the vertebral body is divided into 12 zones. You can use those zones as well as zone depths to then plan an approach depending on where the tumor is. And that helps you devise a means to rotate or extract that tumor from around the spinal cord without causing neurologic injury. So to tie all that back together and look back at our original patient case, we've seen the images a bunch, but just to rehash, this is a 59-year-old male. He is independent, very highly functioning. He had a little bit of extremity weakness, a little bit of reduced sensation reported. He had a history of achondrosarcoma of the proximal humerus, which was resected in its entirety and had been cleaned for over a year at this point. I guess at this point we already all know that it was biopsied. It was consistent with a diagnosis of an oligometastasis of clear cell chondrosarcoma. His exam, he showed a little bit of weakness without frank myelopathy. Again, the images, plain film's a little tough to see. Maybe you can convince yourself down there around C7. There's a little bit of abnormality of the vertebral body, potentially lytic lesion. That's redemonstrated when we see our CT scan. This scan demonstrates instability, a little bit of a fracture or compression deformity of the vertebra. This was actually obtained prior to the surgery, but after the MRI, which is why when you look at the MRI, as Dr. Coleman pointed out, the tumor burden here. Again, it's important to note the involvement of the lateral mass, which can be seen in the top right image there. Which does complicate things when you're talking about removing this en bloc. And we'll look back at the Boreani classification there and see how that impacts things here in a second. Pretty minimal epidural spinal cord compression. You see not really any real cord deformity, and there is a CSF, but there's definitely a little bit of tumor coming out of the vertebral body. I would say is a reasonable point to make. We talked about the SINS classifications. Go ahead and throw that out there. Let's classify this guy according to all the schemes that we've presented so far. He's got a 13. He needs surgery. I think that you have to argue in the favor of surgery for this guy, definitely. So now that we're considering surgery, let's look at the scoring system. So if we look at Tokahashi, we see a score of 11 with an oligometastasis. That pushes us in favor of excision. Look at the Tomita system. We got a score of 2, again pushing us toward excision. Look at the SORG nomogram, and we see it a 30-day survival of over 90%, 90-day survival over 90%, and a 365-day survival predicted of 70 to 80%. So looking back at the Boreani classification, because I think at this point it's reasonable to start considering a total en bloc resection, because you have a young, healthy guy who is who has a high performance status, who scores well on all our scoring systems. Basically that ideal candidate who is someone who has a good chance at a good outcome, and we want to optimize that outcome and ideally shoot for a cure if you wanted to aim for the stratosphere. So planning the surgical resection, we look at the Boreani ring. I flipped the MRI upside down just to match the original diagram over here on the side. I've outlined the tumor burden in red so that you can see it. So basically we're looking at zones 3 to 6C, which means we have to do at least some resection of the posterior arch. We have to get the anterior vertebral body out. And in the process of this, we have to be careful in the separation of the lateral mass component of the tumor from the lamina during laminectomy. We also have to consider the fact that this is in the lateral mass, which does shingle down over the inferior superior articular process. And we have to be able to consider the fact that if we're going to try to rotate this out as one unit, we have to allow that lateral mass to translate around without disrupting the nerve roots above or below. So kind of just to circle back on this guy, it's a physiologically young patient, excellent performance status, good prognosis. He's got an oligometastasis. The tumor is in the anterior body and the lateral mass. It doesn't have paraspinal extension, which I didn't really touch on this, but as you have extension of tumor into the paraspinal area, it kind of complicates things a bit, particularly when you have, the vertebral artery nearby. But in the concept of en bloc resection does complicate things. This guy does not have that. So I think that, I would argue for a two-stage procedure in this patient: posterior laminectomy, separation of the lateral mass, separating the, freeing up the roots above and below so that you could theoretically rotate that lateral mass out without disrupting those or causing an injury there. Following that by stage 2, anterior corpectomy, removal of the tumor in its entirety, and placing a strut and a cage. I think that, for the purposes of this talk, doing anything less for this guy is doing him a disservice, and I think we have a really good chance of having a positive impact on this guy's already favorable prognosis. So with that, I'll turn it back over to Dr. Coleman to finish it out.
Awesome. And Barrett, if you can unshare. There we go. So I think everybody presented a very good argument for their, I actually, for each of your talks, was kind of second guessing myself and saying, yeah, maybe that would have been the best thing for this patient. But the chondrosarcoma histology, the performance status, the desire for, aggressive curative algorithm care is what caused me to make the decision I did. Obviously, a lot of discussion with our multidisciplinary group in preparation for this. And so we chose Dr. Sullivan's approach. My strategy to deal with this tumor was to first go in the back of the spine, open the spinal ring, remove the lamina. And actually, if you think about it, the facet, the right-sided facet of C7 has tumor in it. You must delete the bottom half of the inferior articular process of 6 and the upper half, or the upper majority, of the superior articular process of 1 in order to get those facets away from that C7 facet. And you have to skeletonize those roots, the C6 and C7 roots, in order to prepare this tumor to come out through the next stage. And before you can do that, I actually, from the back of the spine, made a navigated ultrasonic hemisagittal cut. I used a Misonix blade attachment, and I navigate it with stealth navigation. And I make a P to A cut hemisagittally, maybe a little bit more towards the midline. And that prepares this tumor to come out through the front, through the second stage. So that was my operative strategy. This lateral mass and facet of 7 became clear that it was very friable when we were in the posterior stage. It was already sort of broken. So I accepted some intralesional treatment, but R1 type algorithm, I took out the lateral mass actually from the back instead of leaving it on and rotating it out the front. I was worried that once I flipped over to the front, I wouldn't be able to retrieve that posterior element through the front. I wouldn't be able to get to it. So I accepted a little bit of intralesional treatment in the back, but then when we flipped over, I just have some images to show this. This is kind of the navigation, us trying to conceptualize exactly where the hemisagittal cut was going to go. And if you've ever used navigation, you know that you can really navigate anything. You could navigate a Misonix scalpel. You just have to put a tracker on it and register it. So that's what we did. Posterior instrumentation. Then I flipped him over, went in the front, exposed the vertebral artery, finished the anterior hemisagittal cut, and I have some pictures of that. So that's the discectomy above and below 7, so 6-7 and 7-1 discectomies. That's us finishing the anterior hemisagittal cut with the ultrasonic scalpel. that's actually a good look at the cord, and then you can see the posterior rod through the anterior approach. That was an unusual look for me, kind of neat. And then once we elevated the tumor and rotated it out the front, we were able to see the whole C7 and C8 nerve roots, and inspect for any other lesional tissue, which there wasn't. And that's the final construct. So I'd really appreciate, we're going to finish up here. If anybody has any questions, they can keep typing them. I'm going to stick around and answer questions at the end, but I wanted to do the post-test. So I'm going to ask you these questions again. So which of the following factors are contraindications to standalone radiation? So a SIN score of 10 is sort of an equivocal SIN score, but that Bilski epidural compression scale score of 2, that's considered high-grade epidural compression. End plate fracture, radiation allergy, or Karnofsky of 90%. If everybody could vote again, correct your answer if you want to change it, keep it if you liked your first answer. All right, next question. Which histology has the best evidence to support spondylectomy and oligometastatic spine disease? Great. Okay. And what is the essence of separation surgery? Is it circumferential cord decompression followed by radiation, or is it defined by corpectomy, or is it defined by MIS surgery, or is it nothing to do with actual surgery? So let's correct our answers there. Hopefully you learned something from the talk about what separation surgery is. And I just want to thank everybody that participated, not only the fellows and the attendees, but certainly our fellows who did an awesome job putting those talks together, and Dr. Marwaha. This topic is so multidisciplinary and is so dependent on judgment from discussions between medical oncology, radiation oncology, surgery, amongst others, that I was really happy Gaurav could join us and provide some insight. So thank you, Dr. Marwaha, for doing that. I have 2 questions. So we're done. So if people need to log off, go ahead. If you'd like to stick around, I'll stay and answer questions. I'm just going to kind of read the questions that haven't been answered so far. So the first question is, when SBRT is available at your institution, should separation surgery be the first choice? Are there any exceptions for M-block surgery regarding metastatic tumors? So, I hope when you leave this webinar that you consider separation surgery, radical M-block surgery, and even non-operative therapy, meaning ablation, standalone radiation, or medical therapy. I hope you consider all 3 of them. I don't think one of them applies to any and all scenarios. I think a lot of times it's a judgment call. I think the fellows made a great argument why each of their techniques could be used for the case we showed. So that being said, I will say that the vast majority of my spinal metastatic cases that are operative get treated with a separation surgery algorithm, because it is thorough, it is less invasive for the patient, and it has very, very good durable control. So hope that answers your question there. Are there exceptions to go for M-block regarding metastatic tumors? So hopefully you saw the evidence that in renal cell and chiefly renal cell, but there's some evidence for breast and other favorable histologies that if patients have good performance status and there's been a long latency from their diagnosis and they have limited disease, that survival actually can be improved by reducing the total body burden of tumor to 0 with M-block surgery. We don't really call that curative, because obviously it's already a metastatic situation. But my feeling is that the host immunological control of cancer is optimized when there's just a very low disease burden. So sometimes you're wrong. Sometimes you do if you do a very large surgery, even if it's not en bloc, if you do a large surgery, you're just staring down the barrel of inevitable biologic, overwhelming biology of the tumor, and the patients, succumb quickly. So it's not fun to be wrong with that. But I think if you think about the issues we talked about tonight, you can consider en bloc surgery for a wide variety of histologies, not just renal cell. Our next question: do we use navigation routinely? I use navigation when I have a lot of instrumentation to do, because I like the instrumentation to go in quickly and without much futzing. I don't want to introduce poor instrumentation fixation. Not that happens, but it's just, I don't want to use my mental and physical energy on the screw part of the case. For me, I like to use all my energy and focus on the tumor resection and the neural handling and the decompression. So for me, navigation for instrumentation just speeds up that part of the case and gets it out of the way. I think there's an educational value to navigation for fellows, I think, as long as we don't get addicted to it. But for tumor cases, I love navigation because it lets me make blind, sort of poorly visualized cuts with great accuracy. So like this hemisagittal cut on the vertebrae is a perfect example of, it's just not something you're going to be able to see really well what you're doing with X-ray. And so the confidence the navigation gives you that cut is going right where you think it is really great. I think the bone scalpel is nice when you have bad things around the area where you're cutting. Obviously, if you plunge with an osteotome and the cut that I did there, you're in the contralateral vert, you're in the esophagus, you're in the trachea, you're in the mediastinum. A lot of bad things can happen. Also, the navigation doesn't really understand the orientation of an osteotome, if that makes sense. There's some newer technologies that do, but traditional navigation, it's a 2D line, right? It doesn't understand the flat versus the linear part of the osteotome. So that's a complicating factor. Now, the last thing is the bone scalpel coagulates. It really does a good job at limiting bleeding from your bone cuts, which isn't the case with an osteotome. So yeah, I think the bone scalpel is really good for limiting blood loss and being gentle on soft tissues surrounding your cut. Do I worry about the Misonix blade against the dura? The lateral, yeah. So I think your question is probably the heat coming from the blade. The blade will not cut soft tissue. I don't worry about that at all. But I do, if you don't have the water set correctly, I do worry about the heat coming off the Misonix. So yeah, we make the cut slowly. I do a little bit at a time. I keep it moving. I don't leave it in one spot. It's a great question. You have to be a little careful. It's not totally benign technology. All right, I got another question about a patient with lymphoma with severe cord compression with significant neurologic deficits and mechanically stable spine. Would you do surgery before radiation in this radiosensitive tumor? It's an awesome question. What happens when they call you at 2 a.m. and the patient's had 2 hours of dense quadriplegia because they've got this lymphoma pushing on their cervical cord? Well, you're actually okay. If you know the diagnosis, you're okay to give steroids and do emergency radiation. The problem is that will work. It will almost always resolve. It will cause lysis of the tumor. The tumor, as we showed in that very dramatic myeloma case, the tumor will completely go away. It will involute, and the patient will usually recover. But that's a tertiary quaternary tumor center kind of a maneuver. I think a lot of times you find yourself in a smaller hospital where there's not a radiation oncologist that's just going to jump out of bed or immediately bring this patient to the radiation suite, plan them, and deliver. So I think it's not wrong to do limited surgery in order to provide what really matters with an acute evolving neurologic deficit is decompression, right? So whether you do that with surgery or with radiation, you got to do it soon. So whatever modality you can get that patient decompressed quickest with is fine. I just think if you have the radiation option, it's a wonderful thing to spare the patient an operation. And I think that was all the open questions I had. Anybody else have any questions they'd like to type in? If not, I think we'll wrap it up. We're already 20 minutes over. So just want to thank everybody again, the panelists and all the attendees. Thank you very much. And we'll look forward to the next Fellows webinar.